Some of you have hopefully been attending some of our statewide harm reduction summits. If you've been to a harm reduction summit, can you give a little clap out? All right. Wonderful. So we have been having 5 of these across the state, but in case you have missed them, we are going to be hosting 2 more. So we did the first 5 and we got such rave reviews, so 2 more. And those are going to be coming in September. So once again, if you want some information on that, you can look at the program guide, and it has a QR code in the guide. So today we're going to hear from Dr. Ricky Blumenthal, who's a distinguished professor and interim chair of population and public health sciences at Keck School of Medicine at the University of Southern California. They're going to lay the foundation in defining harm reduction and its core principles, share research-backed evidence for harm reduction as a public health and social justice imperative, and explore the integration of harm reduction across the SUD continuum of care. Then we're going to hear from Dr. Not yet, almost. Oh, no, don't hurt yourself. Then we're going to hear from Dr. Brian Hurley. He is an addiction physician and the medical director of the Division of Substance Abuse Prevention and Control for LA County Department of Public Health and the president of ASAM Board of Directors. And he will give an overview on ASAM clinical guidance. I do just want to state that during the break, someone came up to me and thought that the comedian was making fun of Brian. I think that was Phoebe. I'm going to rat you out, Phoebe. But then was very excited when it was Gary. So anyway, sorry, Phoebe. Then Dr. Megan Parch is the Chief Health Officer at Father Joe's Villages. They're going to provide concrete examples on how to operationalize harm reduction principles in a treatment setting. And then finally, we're going to wrap up our panel of experts by hearing from Vanessa Ramos, who is an advisor at Disability Rights California. Vanessa will share her powerful story as a person with lived experience and share examples of how harm reduction principles impacted her recovery journey. So can we have a warm welcome to our panel?
I know. Good morning, everyone. It's great to be here with you. That's right. That was okay. I mean, we'll get going. So it's great to be here. I just wanted to share a reflection I had because I got here early enough to hear the previous panel. So it was great to hear from Brandon and Gary. But let me tell a story about Gary. So I think I first met Gary in like 2015. And USC had a contract with SAPC that wasn't going very well. And so we got to meet with Gary to figure out how to get out of it. And Gary was like, well, I'll help, but, I'm really focused on trying to create this system where we can get Medi-Cal to pay for SUD. And so it was terrific just to see the success. I've been doing this kind of research and in these spaces since 1991. And I can assure you that when I started, 6-month wait for drug treatment was low, right? So to have a circumstance where people are able to get care in a reasonably short period of time when they need it and ready for it is a real achievement. So thanks to Gary and thanks to all of you who've stepped up to the plate to take advantage of the opportunities that some of these policy changes have made. And I do want to just before I get into my talk, finish with what Brandon said, which is, these policy changes did not happen because some anonymous person figured out that we should do better in this space, right? It happened because people got organized and mobilized and called up Congress people and talked to their assembly member and advocated with their governor that there be these changes so that people can get care when they need it. And now that some of that appears to be under threat, I hope that people will remain engaged politically because these are political outcomes, right? As much as we like to say, oh, that person chose to use drugs and this thing, they did that and that was their choice and they didn't have to do that. There's some truth to that. But a lot of what's happening with people is the context that they're in doesn't give them opportunities to make different choices. And the treatment system that now exists in places like LA and in California and hopefully continues to grow is creating a different context, right? Where it might be easier to get MOUD rather than bifentanyl, right? Or it might be easier to get into contingency management rather than use crystal meth again. So that's a created new reality that we created together. So I just want to encourage you all to continue that political engagement, which creates the context for the resources to reach the people who need it. All right, so I'm going to talk about harm reduction. I'll do some of the empirical evidence that supports it. I'll talk about why it doesn't make things worse. And then I'll just conclude with some advice because I'm old and I get to do that. So, part of my main take home, similar to like the political reality that created this emerging treatment system, is the idea that if you want someone to be different or to be better, you should give them the resources to make that happen. And that's what harm reduction essentially is. When I helped found the illegal needle exchange in Oakland in 1992, all we were doing, thanks. Yeah, it's in my top 3 accomplishments. So, marrying well and wonderful children are the other 2. Folks were at risk for HIV. HIV was killing people then, and the system wasn't responding. Right? They weren't going to do anything. And so giving people the means to not share syringes seemed like a simple thing to do. Syringes are inexpensive, and it really worked. And what I'm going to take you through is a history of, there's a bunch of other things we could be doing that have the same impact on people, right? And what I'm going to advocate for you is that, when you have someone across from you, try to give them what they need, right? That's the first step, is recognizing, hey, they're here seeking help. They need things. I have some things to give them, but they might need other things. They might need a hug. They might need a meal. They might need a fresh clothes. They might need a place to go to the bathroom, right? They might need a shower. There are things that we can do that help people get into a place where they're going to be better able to take care of themselves. And those things put them at the center of it. So it's not, hey, I have this theory about how to do substance use treatment, and I'm going to test it on you. It's more like, hey, people have insights into their own lives. The people who have substance use disorder are crazy diverse. They have all kinds of different needs and wants and preferences, and it makes sense to listen to them if you want to have a positive impact. And then I'll just conclude, I'll also cover the whole thing about the negative consequences. I have to tell you, I've grown exhausted by similarly socioeconomically situated people as myself, who often will say, oh, if you're helping people, you're really hurting them. What? Right? People believe that. Helping someone is actually hurting them. I mean, maybe that happens sometimes, but dollars to donuts, just helping people is helping people. Right? And whatever you can give them is better than what they probably had before. And we need to just have that ethic. The point isn't to sort of punish someone into the behavior that we want. That almost never works, right? Even in places like families where people love each other, right? You want to give people the resources to enable the change to happen for them. And that's really the story of harm reduction in the United States. So we know there's this persistent gap in treatment, although it sounds like from what I learned today, it's closing, so that's awesome. Here's the definition. I think they took this down, right? But, just the thing I highlight is a key. Empower people who use drugs. That's it. They have insights into their lives. They have deficits, some of which are their fault, many of which are not. If we give them the resources they need to make change, they will more often than not make the kinds of changes we would fully endorse. This is a version from the National Harm Reduction Coalition. It goes into a little bit more detail, brings up points like, hey, we live in a society that's got these structural problems, right? We create poverty, we disenfranchise women, we discriminate against people of color, we get ooey around folks who are gay, lesbian, or transgender, right? And that ends up having impacts on people's lives. And we need to unwind that. The Harm Reduction Coalition definition gets into some of those pieces of it as just further motivation for why we should take this approach and make these changes. All right. So this is a thing. I'm very proud of this slide. So I did this. This is a study that my friend Alex Kroll and I did back in the early 2000s, so a long time ago. And what I'm going to show you, this is like the empirical evidence of why being generous is a good idea. So if you look at this chart, what you'll see is these sort of 10 groups. So those are deciles of syringe coverage. So what is syringe coverage? Syringe coverage is the ratio of needles, clean needles someone received to the number of injections that they had in a period of time, right? So for this study, I think it was 30 days. So the folks on, I think it's your left, at the bottom, where it's going down, those people had 5 clean needles for every injection, right? And the folks on the other side had 1 needle for every 10 injections. And then the lines in the middle are showing receptive syringe sharing and distributive syringe sharing. And you see a nice, you see this nice positive relationship. So the more generous we are at giving people syringes, the less likely they were to share syringes. And then the purple line, I think that is, that bounces around, that's improper syringe disposal. So it's helpful because it sort of is empirical evidence for 2 phenomenons. Giving people what they need works. And then the other thing is you can do it and it didn't lead to chaos in the streets, right? Like there weren't syringes all over the place. People who had more needles were actually more likely to safely dispose of them than people that had fewer. So, it works. This one's a little even harder to decipher. My PowerPoint game isn't as strong as I'd like it to be. So if someone wants to tutor me on that, I'm open. So if you look at this, think about it as 3 different sets of bars, right? And on, again, the left is San Francisco, and on the right is Los Angeles. And this is data that Alex and I collected in 2013 to 2017. And what we're showing you is number of people who had an overdose, a non-fatal overdose, over time. And the yellow line is 2011-13, and the darker line is 2016 to 17. And so you see that went up in both places. So in Los Angeles, San Francisco, with the emergence of fentanyl, you had more overdoses. And then the one in the middle is people witnessing an overdose, right? And that basically doubled, probably tripled in San Francisco. And then on the right, you see I used naloxone when that happened, right? So that big dark bar on the far side and in the middle shows the change that happened. So in Los Angeles in 2011-13, we didn't have a lot of naloxone distribution. And then we got a ton of it, thanks to people like Brian and Gary and Shoshana Scholar. And you got this amazing response, right? Each of those uses might have saved someone's life, right? I mean, who gets to say they saved someone's life today, right? People are doing that every day in the communities that we live in. They're doing that for the people who are their friends and families and acquaintances. And they're often people who use drugs who are doing that, right? So we gave them a resource. They used the resource in the way that we would have hoped for. And that intervention is probably more powerful than anything else any of us have ever done in terms of immediately resuscitating someone from potential life-threatening circumstance, right? So we can trust people to do the right thing, and we just need to give them the resources to do that. Okay, so let me go through, I'll skip that, talk about that. All right, so let's talk about the unintended consequences. So, when I first started doing this work back in 92, when I reflect back on my career, I think, well, I was really focused on, hey, does this work? And I probably should have been more focused on, hey, does it cause a problem that a middle-class homeowner would not like? Right. So this is the version of that where we hey, we can do things that are good for people and it doesn't cause Armageddon. So there have been studies that looked at increased drug use, study that looked at interest in drug treatment, studies that looked at litter, and studies that have looked at crime. And all of these studies have found that, making syringes available or now pipes available doesn't increase the frequency of use, doesn't make people less likely to be interested in treatment, doesn't make them more likely to throw syringe litter away. And also, does it make them more likely to commit crimes, right? So when you guys have access to the slides, the thing that's important to remember, these studies haven't mostly been replicated because they were done a long time ago, and they were kind of unequivocal in their results, right? So there's not really a research question that we need to ask about these relationships. So does this mean that no one ever throws away a syringe inappropriately? No, it does not mean that, right? That certainly happens. But these programs aren't responsible for that happening. All right, so what does it look like to center people who use drugs? And this last section is really mostly about things that Ricky learned over 30 years that he probably should have learned in the first 3 years. So get ready. Look, so in the time I've been doing this, I have seen awful things happen to people who use drugs. I've seen people continue to get incarcerated and put in places that I know and they know and the rest of us know are not going to create a circumstance when they come out that they're better able to take care of themselves. Putting someone in jail is a powerful intervention that is great at making their life worse. I'm glad you clapped for that. That doesn't always happen. Like, we really believe in putting people in jail. So that's an issue. The other thing is folks have all kinds of other problems. So, the time I've been returned to Los Angeles, so I've been here as a researcher since 98, homelessness has basically doubled, right? So it's harder for anyone who uses drugs or doesn't use drugs to stay housed. Food insecurity is a huge problem. Poverty is getting deeper. You get poor educational attainment and unemployment issues. Like, these are the things that folks have. And then the other thing is that often if people find themselves in these vulnerable circumstances, they've had a bunch of other bad stuff happen, right? So adverse childhood events that don't ever adequately get addressed, elevated exposure to violence, the sexual coercion and assault that happens among women who are unhoused it's difficult to stomach. So the last study we did, about 10% of the women were raped in the last 3 months, right? It's like an ongoing war crime, what's happening to women in these circumstances. And so, I think when we think about what is centering people, it's centering their needs, right? So one of the things I learned, right? So, I'm very proud of my needle exchange work, and that was important and it helped on HIV, but there was so much more that I should have been doing. So much more, right? Because that is a problem that they have, but there's another 20 that are really much more important to them. And sort of getting to a place where we align the resources with the actual felt needs of the population is the most valuable thing we could do, right? Whether it be, hey, immediately getting you into treatment, or immediately getting you into housing, or immediately getting you food, or immediately finding you social support so you can get into a place where you're beginning to feel better about yourself. In terms of the existing infrastructure, if you run a treatment facility, if you run a harm reduction program, I hope you have a patient advisory board. I hope you meet with them frequently, and I hope you listen to them, right? Part of my thing is, I have these fancy degrees and I've won these awards and I'm distinguished with this and that. And the truth is, I don't really know that much, right? My success is only that I've been reasonably okay at listening to other people, right? And then being willing to try and use my scientific methods to uplift their voices, right? Just listening to other people is really important, and figuring out how to engage with them. And then, of course, the other piece is, because folks who have chronic substance use disorder and have had these experiences, adverse childhood events, incarceration, exposure to violence, we need to give them jobs. And one of the great things, and I think Brandon spoke about that, so much of the employment in the recovery world is people who are in recovery. So that's terrific, but we need way more of that so that people have easy pathways to succeed, right? And it's not rocket science, right? If when you want something to happen, you can make it happen if you have the resources. If you put the time in to figure out what it is that folks need, it's not that complicated. It's just a matter of making sure those basic needs are met All right. So the other thing is, and this is sort of like no one here is, well, there's some marketing people in here. I mean, one of the things that annoys me around substance use treatment is like we're against patient choice, right? So like I have access to like 50 different kinds of cereal. That's important, I guess. But the kinds of treatments that are available aren't, or the dosing isn't, or the circumstances that they have to go to get it, right? I mean, the regulations we have around methadone, I realize there's some rationale for some of them, but they don't really, we'd be all better off if it was easier to get methadone than fentanyl, right? You know, the other piece is, so we need to destigmatize the medications. And then we have to realize that life's a journey, recovery is a journey. None of us is finished. All of us have problems. You know, have a little bit more grace in terms of people. I already talked about deregulating methadone. You know, we should be looking, and there's some nice innovation happening with buprenorphine around how to get people on it, how to do it in the context of fentanyl. You know, do you microdose it? Do you go high? Do you go low? And so there's good work happening in that space. You know, some of it is, I think we need more communication among practice. And so I'll do my shout out for Brian, who's a past president, the American Society of Addiction Medicine, who create a lot of the guidelines. That's a great conference to go to. And there's a lot of practitioners talking about innovative ways of making medications for opiate use disorder better available to people who need them. All right. So the other thing, and I think we've kind of won this battle. It used to be that it was very hard for people to remain in treatment because if they pissed off Anthony, then they got kicked out. Or if they wore shorts, they got kicked out. Or if they looked funny, you know, whatever, right? People were making up stuff and folks were getting kicked out. Look, the only thing, you know, worse than not being in treatment is getting kicked out of treatment, right? So if someone's struggling in treatment, give them more treatment. All right. And there are patient groups and organizations out there that you should all connect with. The Liberating Methadone Group, they have a meeting once a month. That's a Zoom meeting. There are local drug user unions in LA and elsewhere. So please reach out to them. So at the end of the day, my final points, focus on people, not diseases. Focus on system change. So grapple with the ways in which the regulations stop you from doing the thing that your heart and your mind tells you would help the person sitting across from you. And then let's elevate the centrality and the importance of people who use drugs and make sure that our systems match their needs and not the other way around. Thank you very much.
Good morning. So my name is Brian. I am an addiction physician. I work for the LA County Department of Public Health. And as mentioned, I do have an affiliation with ASAM, the American Society of Addiction Medicine. I recently passed the tiara to Stephen. So now I'm the immediate past president of the American Society of Addiction Medicine. But it was a really cool experience to be president during the release of the 4th edition of the ASAM criteria and a number of our guidelines, one of which I am going to be talking about. Engaging and retaining patients with non-abstinent goals of care. What are the principles that substance use treatment programs might consider? I don't make any money off of talking about this. I'm not going to try to sell you anything. That said, as the immediate past president of ASAM, I'm not neutral with respect to ASAM. I want to talk about the National Survey on Drug Use and Health. It's abbreviated NSDA for those of you that speak epidemiology. And NSDA is a national household survey, make phone calls to thousands and thousands of people living in the United States. And 6% of people, according to the NSDA, with a substance use disorder are currently receiving treatment for their, or within the past year, went to a treatment program, something we would call like a treatment program, like a specialty addiction treatment program. So 94% don't. So no, if you ask the 94% why they didn't go to treatment, what do they say is why they didn't go to treatment? Yeah, they weren't interested in it. We have a treatment system that is serving a style of treatment that most people with the condition that treatment system needs to treat, people are saying, I'm not interested in it. What's interesting, though, is if you work in an emergency department and you say, hey, you've come in, let's say hypothetically, with an overdose. Do you want a medication that can help stop your withdrawal, keep you from dying, and support your staying in treatment? Most people will say yes. But that is and they can continue to use, right? It's not, the medications don't require you to stop using for the most part, but it's a way of starting treatment where somebody is. That is a different question than, are you committed to abstaining from alcohol, cannabis, and all other drugs for the rest of your life, moving forward? And if yes, then we will start talking to you about the process of not using alcohol, cannabis. It's sort of like saying, come to our weight loss program after you've lost the weight. It just doesn't work, right? Like we have to make treatment accessible to people. If you ask the question differently, and in 2024, NISDA rephrased the question. They said, okay, rather than did you go to a treatment program, they asked the question, did you receive any medications, counseling, support related to your substance use disorder? And the treatment gap there is closer to 81%, not 94%. Now, keep in mind, whether we're talking about a treatment gap of 95% or 80%, it's still a ridiculous, unacceptably high treatment gap. Like, let me be clear. I'm not saying, oh, great, 19%, done. No, but part of the point with a lesson from the National Survey on Drug Use and Health is that people tend to accept treatment where they are. So people are in a doctor's office, they'll tend to accept treatment there. If they're in a hospital, they tend to accept treatment there. If they're in seeing somebody in street medicine or seeing somebody in a community mental health center, like, you don't necessarily have to go to a treatment program to get pieces of treatment. But then that also means we have to actually increase the accessibility of substance use treatment across the board. And that means positioning substance use treatment programs as being an element of specialty care that's available kind of to a bunch of different programs. Like, we're sort of, not everybody, let's say with heart disease, has to go to a hospital. But when people have really bad heart disease, sometimes you need to go to the hospital, right? So we're a specialty system that needs to connect with the rest of the safety net. And the safety net needs to be able to offer treatment where people are. So, within this context, I want to talk about harm reduction services, because harm reduction services are generally grant funded as opposed to Medi-Cal funded. They are, and Dr. Blumenthal really gave an excellent description. So I'm just kind of going to go through this quickly, right? Save lives are cost saving and do not increase drug use or crime. People who engage in harm reduction services are more likely to participate in treatment and stop injecting. People do and can change. And they can change all the time, right? So when a lot of us think about harm reduction services, we think about syringe services. And yes, syringe services are a component of harm reduction. And biohazard waste is a component of harm reduction. Naloxone distribution is a component of harm reduction. Addiction medications can be prescribed and administered in a harm reduction framework. Drop-in centers are part of harm reduction. Pharmacy access is part of harm reduction. Connecting people, it's all part of harm reduction. And I want to be clear here. I'm talking about harm reduction services. There's also a harm reduction philosophy, right? They sort of exist together. Anyone working with people can employ a harm reduction philosophy. You can do so as a housing provider, as a medical provider, as a substance use treatment provider, as a mental health provider. Anyone can work with people on making any positive change. That's a philosophy. These are the types of services that tend to be offered in either generally health department certified or physician prescribed harm reduction services. But we have this idea that you have treatment over here and harm reduction over there. And I sort of, sometimes when I was in medical school, I remember being asked, well, what do you believe in, treatment or harm reduction? As though they are somehow somehow opposing each other. Kind of like that. You know what I mean? Like, if you do more harm reduction, then somehow you're keeping people out of treatment. If you do more treatment, then you're not work. But the truth is, People come into and out of treatment all the time. People come into and out of treatment all the time. People are like, yes, I'm interested in change-focused services to stop or reduce my use. Never mind. I'm no longer interested in that. Never mind. I am interested in it, right? Like, people come back and forth all the time. So if we were to really organize a system around the needs of our community, we would be blending these services. That is to say, we would build a system where people can come into and out of treatment and into and out of harm reduction and actually offer the full set of services that people need at the time that they need them. Harm reduction services are inherently patient-centered, right? And the ASAM, the American Society of Addiction Medicine perspective on this, is we tend to think, and in fact, there's even recent executive orders that sort of reference like one way of doing things, right? We just need to institutionalize everybody, or everybody needs this or that. And we have a history in substance use treatment of kind of participating in what are called program-centered care, building boxes that people fit in. But it turns out people are not box-shaped. And so that means if you call yourself, we run a 90-day residential treatment program, you're probably planning to deliver somebody about 90 days of treatment. But what is the right amount of treatment for folks? Well, I don't want anyone to be in residential a day longer than they need. And for some people, a couple weeks, they're stabilized, they have robust social supports, they can transition out of a contained setting to the lowest, the least constricted setting, and continue their recovery. And I want people to be in recovery their whole lives. And for some people, 3 months of residential treatment is just getting started. It's not enough, right? People need more, right? So the whole idea is that we build services around people, and harm reduction services are part of that. So within this context, DHCS, thank you to DHCS, worked with ASAM to develop this clinical guidance and background document. In fact, people in LA, including my boss, Gary, worked on the writing committee for this ASAM clinical guidance background and considerations document. So many of you in addiction treatment are probably familiar with the 12 steps. Well, this document has 10 steps designed to address the core dilemma of people are denied admission and discouraged from treatment when they exhibit the condition for which that treatment is indicated. That is the core dilemma that ASAM developed guidance around. Part of this guidance is that people, their readiness to participate in change-focused treatment and continuing to use, and there's lots of people doing between, like, I want to stop using the fentanyl, but I'm not ready to stop using the cannabis. Like, there's all sorts of different permutations of people's individual goals. But we want services to be accessible throughout somebody's readiness. So these are the 10 steps. Part of the 10 steps starts with engagement. If you're not actually talking with somebody and engage with somebody, it's impossible to do anything else. So engagement requires us to actually descend to the particulars of somebody's life and understand their ideas, their values, and their preferences. And we do this, or I do this all the time, when I talk to patients around tobacco products. I'm a physician, and I talk to patients around smoking tobacco, and I am thinking heart disease, strokes, cancers. They are oftentimes thinking about yellow teeth, smelling, and cost. And it is so much more important for me to be on the patient's page around cost, yellow teeth, and smelling, because they may not even care about heart disease, strokes, or cancer. That may not even be relevant to them. So understanding, it starts with actually engaging, creating a welcoming environment that is trauma responsive, because it is more often than not people in substance use treatment are impacted by trauma, right? Do not require abstinence or commitment to like lifelong abstinence as a condition of initiating treatment. Now, I am not saying every residential site of care has to have a system for on-site drug use. That's not the point. But the point is, when people come to residential, maybe they're just coming to take a break. They don't intend to stop forever, but they're just sort of coming to take a break while they're there. That we can work with people even if that's where they're at, right? They want to be here for a period of time. Great. Let's get started. To optimize clinical interventions, again, really focused on engagement. People come into and out of care. We need to re-engage them, right? We don't administratively discharge people as the first thing. If somebody does use in a residential side of care, the next step is a conversation, not a discharge, right? We talk to people about what's going on with them, right? Like help me understand what are your ideas, what are your values, what are your intentions? And then we use that conversation to guide what's next. And we can't do any of this if we don't have a team that's on the same page. And this is actually, I think, the hardest thing in executing a low threshold system of taking care of people. It's if we always have staff that are turning over and we're always bringing new people in and new people that may not necessarily have received training in this or a background in this or an understanding of this, it's really hard to systematize this. So this means a lot of the conversation earlier had to do with investments in the specialty SUD system. We have to make investments in the specialty SUD system where people, these are desired places to work, where people stick around and they're able to use their skills. That's really, really important if we're going to pull this off well. Now, there's been a lot of federal guidance. The previous administration had a version of SAMHSA that published the low threshold models of care for substance use disorders. This SAMHSA advisory is actually, interestingly, no longer posted on the SAMHSA page. But if anyone wants a copy, I have an electronic copy, happy to share it. But this table, thank you, but this table actually came from a study of buprenorphine, which is a treatment for opioid use disorder, really contrasting high threshold care with low threshold care. So high threshold care works something like this. You come in, you do your assessments, you answer all my questions, you stick around for a while, and then we might schedule you at some point later for a medical visit where that person may or may not prescribe you anything. And if you do get something, you get something along a rigid schedule, and there's all kinds of requirements in order to get the prescription and to take it. And that's high threshold. And we have a long history in addiction treatment of being high threshold. Look at the previous, the current version of 42 CFR Part 8, which is opioid treatment program regulations, is currently lowering the threshold. We now permit individualized dosing. We permit take-homes at the first visit. We permit more flexibility. But the previous version was no take-homes in 6 months. Can't be admitted if you've had opioid use disorder for less than 1 year, which is crazy. It's sort of like people have 9 months of opioid use disorder. You're like, well, keep using it in 3 months. Maybe we'll consider admitting it. Like, that's nuts, right? But we have had so low threshold is like, hey, what are you here for? If somebody says, I really need a dose of buprenorphine, I'm really sick, we do that immediately before the ASAM assessment. Before we've done all of the enroll, because that's the thing that's going to help people, as one example, right, for opioid use disorder. So recovery is a continuum. People come into and out of treatment, into and out of readiness all the time. Part of this is better blending substance use and harm reduction services. This requires culture change. This requires looking at, are we seeing more people in our system earlier in their readiness? And this feeds really well into LA County's reaching the 95% initiative, because there's a lot of people who are not accessing treatment that if you lower the threshold of treatment, you make it easier for people to get in, and treatment systems continue to engage people even when they've returned to use, you make treatment, for lack of a better phrase, stickier, right? Like more accessible, and you keep people engaged for longer. The traditional approach, again, high threshold versus R95, says we will work with you kind of no matter where you're at, right? And we will build the services we have around you. With that, I'm going to turn it over to the next presenter, Dr. Parch. Thank you very much.
Good morning. I want to just start by thanking our partners from the Department of Healthcare Services and those folks who helped to put this event on. It is an honor to be here among friends and like-minded individuals. And I think during a time that's really complicated and challenging,
where we lack concreteness and how things are going to be moving forward. It's really inspiring and motivating to be among a group of people like this who are carrying the charge to improve the health and well-being of our community members, no matter what tomorrow looks like. So thank you for being here and for being a part of this. And it's a pleasure to be here with each of you. I am grateful and humbled to speak on behalf of my organization and excited to share with you the way that we operationalize harm reduction philosophy and trauma-informed care through all of our services and supports. And that's what we'll be discussing this morning. So I don't need to tell you that at the national, state, and local levels, homelessness is a crisis. Each of us who walks outside these doors during break will come into contact with at least one individual who is experiencing homelessness or who is unstably housed. And many individuals, sadly, are experiencing hidden homelessness. We aren't able to see all of those folks who are couch surfing, who are doubling up, who are staying in their vehicles. We can't get to all of the people who are in the encampments and the canyons and so forth. And so these numbers in some ways are understated, as we know. And sadly, in San Diego, where I live, we see more individuals falling into homelessness on a month-by-month basis than being moved out of homelessness, seeing that resolved. And so we feel sometimes like we are pushing against a rising tide. So I'm lucky enough to work in an organization called Father Joe's Villages, and we're located in East Village in downtown San Diego. And this gentleman right here, Father Joe Carroll, took over the organization in the 1980s, and his idea really was to create this one-stop shop. He's kind of an OG harm reduction kind of guy. And he said, if we have everything that people need in one place to resolve their experience of homelessness, then we're not promoting a one-size-fits-all strategy that we know is very costly. We are right-sizing services to meet people's needs and goals, their wants, what it is that they need today, and what it is that they may feel that they need in the future, in those tomorrows. And so by creating really this campus, a village, as we call it, this one-stop shop, we have a broad array of services that engage people in meeting basic needs and then hopefully moving beyond just surviving to a space of thriving. So our mission at Father Joe's Villages is to prevent and end homelessness one life at a time. And again, at a time where we see rising numbers of individuals and families and sadly older adults and veterans and so many vulnerable populations falling into homelessness, it can be debilitating thinking about the number of individuals who require help. And so we focus on that one unique individual in front of us or that family in front of us at any given moment and what their unique strengths are and what their resources are and also what their challenges are and how we can use our array of services on our campus to help them to meet the needs that they have as they present. Our vision, of course, is to create a San Diego where everyone has the resources needed, not just to survive, but to thrive, and a San Diego without homelessness. And we do all of our work through the spirit of our creed, and that's compassion, respect, empathy, empowerment, and dignity. So meeting each individual with those things, whether that's a community partner who's joining with us in this important work, or whether that's the individual who's the recipient of services, whether that's my colleagues who I get the opportunity to stand shoulder to shoulder with. So as I'd mentioned, Father Joe had this idea of creating a one-stop shop. And as you can imagine, seeing here this array of services, it was not cheap to pull these things together. Father Joe dubbed himself a hustler priest, right? And he was not beyond finding all sorts of means to engaging all of the people in San Diego who had any sort of means, any form of means to help us to promote our mission. So he engaged a number of people, and it was, can you volunteer? What can you give? How can you give? Can you give back? Is it money? Is it supporting our campus in some way? Is it donating to our retail thrift stores? Anyone here have a bonus boat or vehicle? We'll sell it for you. Let's talk afterwards, right? You let me know. If you've got a bonus boat and vehicle, I want to know you in general. So we have a huge array of services on our campus. And again, this is harm reduction at its finest. This is making sure that there is an open door and accessibility to things that people need when they need it on their terms. It's meeting people where they're at. And so whether today's need is to engage possibly in looking into shelter services, or I need a meal, or I'm curious about how to access a computer, I need to work on resume building, I need appropriate interview apparel, all of these different things, therapeutic childcare, chaplaincy, all of the things that may be needed in somebody's journey to rebuild and resolve their experience of homelessness. So I'm going to be sharing a bit with you about specifically the health center where I have the pleasure of working, but also very broadly the way that Father Joe's Villages over time has infused more and more of trauma-informed care and harm reduction philosophy in the way that we package and provide our services. So in the Village Health Center, I could humble brag to you about my team forever, but I have 8 minutes and 56 seconds and counting, so I won't. What I want to focus on instead is some of these services here that have an asterisk beside them. And I want to talk with you about why we did these things and really how they reflect a harm reduction approach. First, I'm going to talk to you about our nurse triage. Sadly, we know that individuals experiencing homelessness have so many challenges and barriers that keep them from participating in care. The model that we have says we care about you, trust us, come back in 3 weeks on Tuesday at 2:30 p.m. We care about you in 3 weeks, right? Does that work for our folks when their medication is lost or stolen the next day? No, right? And also because of those barriers and challenges, many of those folks who are scheduled 3 weeks out aren't going to make it to that appointment. So what do we do when we're in a system of care that's trying to engage people in future appointments that we know that many times they can't make? And we have a number of individuals who need something same day urgently. So we're always looking at ways that we can kind of blend those two needs. And so our talented registered nurse team welcomes patients into the health center, does a clinical assessment, and then finds where those canceled, missed, or rescheduled appointments are and plugs people in for the service that they need same day. So that if Bob is missing that appointment in 3 weeks on Tuesday afternoon at 2:30 p.m., Susie benefits from it, right? And then when Bob, having missed that appointment, says, oh, I need to reinitiate care, and when he walks in a few days later, we're able to meet that need for him as well. When I reflected on our metrics from last month, on average, for the days that we were open throughout the month of July, 40 individuals walked in on a daily basis. And we know that some days that's 20 and some days that's 60, right? But 40 people on average. And 35 of those individuals each day on average was served through a same-day appointment, which is really exemplary. Now, the question is, what happened to those other 5? And we care about that too. And those are things that our data and metrics are helping us to figure out a path forward so that 100% of people who walk in each day have access to the care services that they need, be it a tooth that needs to be extracted, which keeps them out of the emergency department and from receiving unnecessary pain medications, or whatever else it might be. So we also have an on-site lab. Anyone here been to primary care and they're like, here's the list of, LabCorp locations, right? Go out at your leisure. Well, you have a vehicle and you have a cell phone and you have someone who's going to remind you and you got a doctor who's going to harass you and they know how to do that because your cell phone has minutes, right? Your voicemail box isn't full. All of these complications and challenges. And so having an on-site lab means that we're able to provide people with that service without sending them away. We're able to get that critical information about their care more readily. We're helping people to navigate their insurance benefits. How many people abstain from care and don't engage with care providers because they don't know how to speak health plan, sadly? None of us do. And so having people help navigate the application process, how to engage with the benefits that they have and so forth is so important. We realized that there were so many individuals who couldn't make it through the door into brick and mortar. Shame on us for expecting people to come to us. So we created a program in 2019 to take care out into the community. And now we have 3 vehicles that deploy. It's not mobile medicine, it's backpack medicine. Our team suits up, they show up, they go out, they're consistent. They become those trusted assets and advocates. And 20% of people that we engage in the community end up coming into brick and mortar, which is a great outcome, right? Because we're embedded in a larger array of services on our campus. And then we can say, do you want to get into shelter? Do you want to know where the public lunch line is? What else can we do for you here? We provide people care in the modality of their choosing, right? All of these are harm reduction, providing integrated care, same day care, For those of us who know the way that healthcare is compensated, it is maybe not the wisest business choice to engage people in a number of care services within a day, but it's the right choice for the people that we serve, right? Who are we to stand in the way of what they need to become more well because financially it's more viable? So we know that there are a number of barriers to care that all of the individuals in our communities who are unstably housed, and especially those experiencing substance use disorders, are experiencing. And at the end of the day, I think we can all acknowledge that if you don't know where you'll safely rest tonight or where your next meal will come from, the idea of engaging in any form of care service is unlikely, right? That is higher up in Maslow's hierarchy of needs. We are not there yet, right? So when we as providers are like, hey, you're due for a PAP, they're like, yeah, right. Now, we know health outcomes of individuals experiencing homelessness are terribly dire. And sadly, the research tells us that folks who are unstably housed will die 20 to 30 years sooner than their housed peers. And add to that the influence of substances that are available to individuals in our community that they often are using so that they can remain awake and protect themselves from being victims of violence, as we've discussed. Sometimes these are not just coping strategies, these are survival tactics that individuals are employing so that they can live another day. So, what do we do about all of these things? Well, you all know, right? You do this too. This is harm reduction at its finest. There's so many illustrations of harm reduction and how it works in our communities. And we've had a track record of so many different services and programs, not just in the health center, but across our campus, where we've been able to implement our harm reduction expertise. Project 25 was a SAMHSA-funded pilot that said if we engage 25 of the most frequent users of EMS and ED services, can we shift the tide? We have a day center that engages people 7 days a week and provides them access to laundry, to showers, to all of these things, right? That's that foot in that door. It's the starting point of the conversations. We're there, we're accessible. We have low barrier shelter. And one of the unique ways that we implement harm reduction and trauma-informed strategies there is we invite individuals who have companion animals and therapeutic animals to participate in our services and programs. We're a nationally recognized model for co-sheltering through an entity called My Dog Is My Home. We have some upcoming open houses. And so if you are considering transitioning your program to something like this, let's chat afterwards. So we had to make organizational commitments and strategic goals. We said we want to engage people through harm reduction strategies like the recuperative care program that we created on our campus, our medication-assisted treatment that provides same-day induction. When someone walks in and says, I'm sick and tired of being sick and tired, we said, you're in the right place. We'll care for you here. Come in. Let's start today. We started our street health program, as I stated, but then harm reduction shifts and changes. And harm reduction for some folks will be when they say, I'm ready. We can't say, I'm sorry, there's a wait list, right? Because that motivation ebbs and flows. We need to be able to do something today. And so this fall, we'll be opening a detox program, a 44-bed program. And we also, at the start of this year, changed one of our shelters, a 248-bed shelter, to sober shelter, reaching independence and self-empowerment. Because again, we need our clients and community members to have power of choice. And what looks like harm reduction for one person shifts to something else in the future. Harm reduction for some people is I won't go into congregate shelter because I'm worried about the volatility of other people's behaviors. I can't promote my abstinence or sobriety. I can't reach my goals when I know that the person sharing a bunk with me is using substances. Harm reduction for that person looks different than the other person who's at a different starting point. We're meeting them all where they're at. Now, wasn't without its challenges, right? Engaging board members, training our team, equipping them. We need to assess, we need to innovate, we need to implement and repeat. What I don't have, somebody else has, right? We create partnerships, we leverage them, we get people access to the care services that they need. We fill cracks in the continuum of care in a number of different ways. And what it comes down to is we achieve our mission of ending homelessness when we're able to continuously innovate and be creative and retool our services to meet the needs of people today, which will look different than the needs of people tomorrow, which will look different than the substances that they're using next year. That's the reality. And if we can't be agile as providers, we're not going to be able to do the work that we need to do to save lives. I welcome continued correspondence with each of you. We are not in a space of competition. We are in a space of cooperation. If I have information that I can share with you, I'd love to do so, because I would love if Father Joe's Villages was put out of business. I would love if there weren't continually individuals experiencing homelessness that needed our care and support. And I know that collectively, working together, that we can make things like that possible. So thank you.
Hi, everyone. Oh, shit. I'm fucking up already. I'm sorry. Hi, everyone. My name's Vanessa. I'm so happy to be here. I always get so emotional, but I feel like I'm amongst my friends, and I know that many of my friends are in the room. And we do recover. And and it's really amazing to watch the state move in a way where I'll be gentle with my words. Like the mental health side of things, in my observation, it's more of a little bit of a shit show, if I may, where the substance use piece is a little bit more of a lane where many of the solutions have come from our own lived experience. And yeah, big shout out to us for that, right? Because as addicts, as drug users, we were born into like criminalization, right? Like people saw me on the street, needles in my arm, right? And like shout out to harm reduction, because I'm someone that I had my rig, and I remember my rig was my baby. I used to like bandage it up, and I remember clearly just like rubbing it on the curb to make sure that it was sharp enough to enter me. And I remember my attachment to my rig or to my pipe wasn't an attachment that was born out of nothingness. It was born out of attachment where I needed a full connection to my supply of medicine. And I love how Salvador Dali says, like, I don't use drugs, I am drugs. And I feel like I've reached a point in my recovery where like I connect with that more than ever, because in my life, I understand that I was born out of rape. My mom is queer. My mom just had top surgery. So back in the day, I'm in my 40s. Shout out Botox and hair dye. But woo woo, yeah, right, yeah. I love how like in the rooms, like we got that good lip filler and shit. You know what I mean? Broke as hell, right? We know that good tax dollar, but yeah, I I know that for my mom, employment wasn't something that she really could have, because my mom in the 80s, was bald and had, like a boy cut, and she would bind her chest down, and in the, 80s, in the 70s and 80s, people were still dying of AIDS, right? And employment for someone like my mom wasn't something that wasn't automatic, and being accepted was also something that was not automatic. So selling drugs for her was something that was, a real need, and as a result, she ended up, being raped. And I thank her for having the strength to go through with the pregnancy. I want to say that the stigma behind drug use runs so deep that the Americans with Disabilities Act even exclude people who use drugs. So people who use drugs aren't protected under the ADA, and at Disability Rights California, we are working towards changing that. And we know that it may take 10 years. We know that it may take 20 years, but that is where we're headed. That is what we're going for, which is why really, when I'm asked to come out and to share my story, I do so. And it's why our executive director, Andy Imperado's like, I don't want a lawyer leading substance use. I want Vanessa leading substance use because she's a basehead. She understands, and like the comedian said, I could say that, but like, my tongue is still kind of burnt. My kids are always like, Mom, why does your tongue look like that? I'm like, mind your business, mind your business. But where I'm going with it is that what LA County has done with the reaching the 95% isn't just something that could be done in such a large county. Reaching the 95% is something that could really be done county by county, and I open myself up to help in any way possible. And I want to thank Dr. Brian Hurley and his team for having the templates ready for the other counties to model, because we understand that sometimes when we hear about harm reduction, especially when we come from treatment settings, it kind of shakes us up, right? Because you're asking us to go against everything that our life has depended on. Like, I worked hard to get my 30-day chip, 60-day chip, 90-day chip, right? I worked hard to get my, sorry, I'm looking at Marlise. I cuss. I'm sorry. It's okay. All right. I worked hard to get my punk ass into Tarzana Treatment Center. And you know what? Honestly, right? I told Tyler, and Tyler, thank you for your courage and for your support in me. It means the world to me, because I know that that you didn't have to support me in this way, and I thank you so much. But I want to say that, what Brandon was talking about is very real on the daily calls and getting in there, because I come from the times where I went through Cry Help, I went through Impact. I used to have a spoon that I would dig my own grave, because I was so misbehaved that I had to dig my own grave. And they would have me wear a sign. I don't know how, if people remember those days, but they would have me wear signs, or they would have me hold mud because I wouldn't tell on my friends and stuff, until the feds showed up, right? I was like, well, you see, what had happened was, I'm kidding. But I remember to the day, Tarzana Treatment Center's number is 818-996-1051. And I remember that number. And I remember they had a payphone right outside Tarzana, because I used it from Hollywood, go all the way up to Tarzana and use the payphone from outside and beg them to let me in. And I remember my mom was still using and still dealing. So for me, Tarzana Treatment Center was my home. So when people talk about the types of changes that are needed, it's really important, because our friends are dying from fentanyl overdose. And, I thank you. Oh, my tummy. And I know that Brandon's here, so I don't want to get my PC card pulled or my sponsorship card pulled, but with the women that I mentor through Cry Help, I talk to them about how to use drugs. I give them Narcan, because I don't want them to die. And sometimes in treatment, we have a culture that the groups are very based on how to stay clean. But I'm more about how to use drugs, because I know everyone's like half, but it's okay. I'll clap for myself. How about that? Yeah. Because I know that when I'm given a choice, I choose to live. I choose to parent my kids. I choose to pet my cats and go to work and do hard things, because I know that gives me purpose. Being able to learn how to, distribute Narcan and bring people back to life and those types of things, that doesn't make me closer to drug use. That makes me closer to understanding the purpose of my life today. I just want to share that many people are affected by drug use, and that has been the case for a long time. I remember when I would use on the street, I'd be like, damn, yeah, motherfuckers look scandalous, And then when I started escorting, because I did do that, I am sure I'm the only one, but okay. And that's the point. We get jobs, we get clean around this motherfucker, we get jobs in treatment, we get right, and then all of a sudden we change who we are. Who we are fundamentally changes, and we carry those biases into treatment in the way that we serve. And I'll tell you this, I remember when I was escorting and I was like, damn, you high-paying motherfuckers are just as nasty, are just as rowdy. But there's something that happens when people have money and people don't. So the employment piece is so important in what we do. And I want to, do a special shout out to my dear friend Jason from Share, who's here, and my beautiful sister in recovery, Carolina Ayala, who's here, and they've got a panel on peer respites coming up. And I really hope that you check them out, because when SB 803 passed, that is a bill that creates a mental health peer lane that also includes substance use. There was a lot of stuff that went on. But now when we're watching the delivery of services and the changes with DHCS, we're seeing that things like peer support are almost viewed as secondary or as not important, because in the SUD lane, we have the RAD-Ts. But we understand that the career path for peers and the career path for SUD is not something to be done separate. It's something to be done together, because we know that our treatment staff, they're already really busy, and their passion is an SUD. That's what they want to do. They can't just pivot to whatever we're dangling the money carrot. So they're like, okay, I'll do this. Okay, I'll do that. Okay, I'll do that. And it's like, no, let the RAD-Ts be RAD-Ts. Let the KDAC folks do the substance use work, and allow people that live with mental health disabilities that have used their life as a living proof that they heal. Allow us to deliver peer support services in an authentic way, because I know that for me, what I do as a 12-step sponsor and what I do as a peer support worker, because I also do some of that, just not like I'm not paid for, but I'm trained in peer support, so I can't split myself, is with a lot of my sponsees, I'm noticing, what? They need peer support, because as a sponsor, I pick them up every week, buy them a little package of cigarettes, you know what I mean? And do the whole, go to the meeting, do the step work, do all that. But what they need support in knowing how to navigate conflict resolution without feeling like they're going to be kicked out of treatment. What they need is access to on-site health services, because as someone who uses drugs, the minute that even if I show up nice, when I go to my doctor, when they see my history, the stigma that I receive is really messed up. And because of the drugs that people are using today, I'm seeing more and more people need access to on-site services. You know, people also need access to transportation. It's one thing to call treatment, but how are you going to get there? You know, people need to be able to get there. And if those services exist, we need to work towards showing people how to do that. I had so many notes. Oh my God. It's like I have like a delusion filled with amazing notes because everything that people were saying is so important. But if you forgot anything that I've said, I want you to know that hope and change does happen. Dr. Alice Glaycorn back in the day in Santa Barbara hosted the first harm reduction conference, and that's when Santa Barbara County was operating mostly as mental health. Dr. Glaycorn, I thank you so much for the work that you did. Dreams do come true because now here we are in Long Beach, California, 2025 at the SUD conference, and we know that as counties prepare to pivot, let's work together to ensure that SUD does not get lost in the mental health continuum as it gets rolled out. Let's advocate for the services that we need. And let's allow the mental health peer support workers to do their job. Do not make your RT, their rad Ts, whatever the fuck it is, peer support. There's a whole other career path. They're called peer support workers, and God bless you all. Bye.
Oh, so good. Okay.
Hello?
What questions do you have?
Or comments?
Conversado. Bonito. It'll
I have a question over here.
Hi, Ron Schnese here from Las Vegas. Good to see how you guys are doing it out in California. I don't really have a question. I just wanted to comment. Vanessa, thank you so very much.
It's over.
Peer support is its own field. Role clarity is very important, but thank you for calling out the field as providing some of the most stigma in treatment services. In fact, that whole panel did a great job doing that. So thank you for reminding us all to check our biases.
I have a question over here.
Hi, this is to Vanessa. Thank you for sharing your story. My name is Anna, and I work at Neighborhood Healthcare in San Diego, and I'm a peer support specialist, and we do street medicine as well. And it's an honor to work for an organization that takes people like myself and that in recovery. It showed me how powerful I am as an addict and as a woman in recovery, because like a lot happens, and places like this that give us an opportunity to come and share our story are just empowering. And congrats to you on your success as well.
Oh.
Thank you. Vanessa, the few patient you referred to the shared mental health here, and I know that we pursued the curriculum on a number of patients of what
Medical peer support specialists are being educated on, and I'm curious to know if you're aware if there's any feedback or if there's any opportunities to enhance the education that's SED specific so that the mental health peers don't end up working in substance use disorder programs with a misunderstanding of what their role is as specialty peers in the workforce.
I don't know how to try. Can you hear me?
Yeah.
Yeah. Oh, fine. Hello. Brandon, thank you. That's such an important question. What Brandon's question is related to is in the world of peer support, California has a curricula that is led, and there's organizations that facilitate this, and you can now become a certified peer support specialist, right? And currently, although, and this is much like BHSA, I swear, I promise, because the mental health folks took the lead in developing that curriculum, and it was not done in tandem with SUD providers, much like what's happening with BHSA. The mental health lane has done this before. So as substance use folks, we need to organize, and we need to ensure that what our needs are uplifted. I I hope folks from Cal Mesa are in the room, because I think that a good next step is to allow for ASAM for those recommendations that Dr. Hurley highlighted, for that to be what is the gold standard as far as SUD, because within peer support, within the core competencies, some of the things that peer support workers do is they're able to provide crisis resolution. They're able to help with the navigation of services. They're able to do things in a way that they have been trained in for 80 hours on how to navigate peer to peer. And that power imbalance sometimes in treatment, where it's like, I'm the staff, you're the client, that creates a tendency for cat and mouse games. I know that in LA County we have Painted Brain, we have Share. I know in Riverside you have the Happier Life Project. So I urge you to partner up with peer support organizations in your county, people that provide those peer supports, because with the changes in BCHIP and Prop 1, if we don't support those peer-run orgs, they're going to go away because the money didn't reach them. So understanding peer support and really encouraging for Cal Mesa to connect with like Dr. Hurley to make sure that the ASAM is how we're doing it, I think is very needed, because the SUD perspective was quite frankly left out. And in the SUD world, you don't need a peer support specialist because you have a RAD-T. So the reimbursement, right, is off. But what we're going to start seeing with the BCHIP funding is the person who's primarily mental health with substance use is going to start acting a little wacky. And I could say that because I'm nutty myself, and my psychiatrist can attest to that. Being in a SUD setting, right, there's a certain culture amongst people who use drugs and getting clean. And you're going to have an oddball here. You're going to have an oddball. You're going to have people that are not fitting in and assimilating because their issues may be a little unmet by the current status quo. Does that make sense? Yeah. Thank you, Brandon, for the question.
Wally, you go next.
Good morning. I'm Alice Glycorn, and I liked your presentation even before you mentioned my name, Vanessa. Thank you. But some of us have been doing harm reduction for more than 30 years. And about a month ago, we had a real throwback Thursday with the executive order basically repeating what the first Bush administration told us, which is you can't have harm reduction practices, you can't have harm reduction philosophy, right? And joke's on them, because you guys are up here describing all the wonderful different things that are being done that have all the proof behind them and that everybody accepts. The only reason they're being objected to is because we're calling them harm reduction. And if we've learned anything in the last 30 years, words have power. And people who like to throw things like to throw harm reduction under the bus. So everything you can take away today is all these things are wonderful. All of them work. Just choose how you demonstrate them to the world. You don't have to call any of them harm reduction. You can keep doing your thing without calling them harm reduction. And no one will ever object because when you get right down to it, you know it's the right thing to do.
Just as a quick response to that, I want to say thank you for making that point. There's a lot of euphemisms that we use in all sorts of settings. We talk about meeting people where they are. I like to talk about aligning services with readiness, which is very broadly applicable. We talk about overdose prevention. I think there was an intention of using the term harm reduction here because I think this is an important term to use in this audience, but you make a really good point that when you're writing grant applications, particularly to federal payers, being judicious around how we frame the work that we do is really important. So thank you for your comment.
We're addressing social determinants of health, right?
Yeah.
We're making sure there's no wrong point of entry.
Yeah.
Hi, Vanessa. Thank you so much for speaking today. I've heard you speak before, and you're just a wonderful speaker. I'm Prue Cooper. I work for Pacific Clinics, and I actually oversee our peer support services training curriculum. Interesting that you say what you said, Brandon, because just yesterday I got a request from a county to do CE specific around substance use disorder, so training peers to work in the SUD environment. And the comment was, and I know Cal Mesa's in here because I saw Lucero earlier, but the comment was, can we please have a 40-hour specialty for SUD in the peer support services category?
Thank you. This will be the last comment or question. Introduce yourself.
Hi, my name is Carolina Ayala. I'm with the Happier Life Project. Hi, thank you so much to everybody that was up there. Vanessa, I love you. Thank you for giving the shout out. Thank you for saying that to hear that Cal Mesa said that. We did speak about this for the training for SUD peers. We had approached the Happier Life Project Cal Mesa when this first started about a specialty for 40 hours, which we call recovery coaching. It's nationwide and it exists and it's specific for SUD. And what was stated at that time early on was that the 80 hours was behavioral health and it was integrative and that it covered both areas. However, learning that in the 17 core competencies, not all 24 agencies that provide the training really emphasize what we need in SUD. And there are people that are mental health, primarily peer support specialists, no experience in recovery from substance use that are serving our population, and it's not meshing, and that is a problem. And so, yes, with the Cal Mesa people, if we can discuss, there's already curriculum. We have it in Spanish and in English. It's already part of IC and RC. We just need to bring it up, get it accepted, and get it moving within our systems. Thank you.
Awesome. Okay. Thank you.
Incredible panel. Thank you so much.